So this is our introduction on our case study of premature rupture of membranes or PROM. Premature rupture of membranes or PROM is the rupture of gestational membranes prior to the onset of labor. Preterm PROM is a term used to describe membrane rupture that happens before 37 weeks of gestational or PPPOM. PROM is when the membranes, also known as the amniotic sac, holding amniotic fluid rupture before labor begins. Premature rupture of membranes or PROM occurs when the amniotic sac, which surrounds the fetus during pregnancy, breaks or ruptures before the onset of labor. This event is commonly referred as to the water break. The amniotic fluid surrounding the fetus starts to leak or gush out through the vagina. Without amniotic fluid, the risk of infection, premature birth, and other complications increases. Statistics. So in the worldwide, premature rupture of membranes is a common condition across the world, with a relatively higher incidence in Africa. PROM occurs in up to 10% of all pregnancies. Preterm PROM accounts for approximately 25% to 35% of all preterm births. PPROM occurs in about 3% of pregnancies. Studies shows that PPROM is more likely to affect twin pregnancy. In the Philippines, it is estimated that 8 to 10% of pregnancy in the Philippines are affected by PROM. In Mindanao, a study conducted at the Bamenda Regional Hospital in Cameroon found that among 387 participants, 19 had PPROM, resulting in the prevalence of 4.91%. Of the 57 preterm deliveries, PPROM accounted for 33.33%. Cesarean section. A cesarean section, also known as a C-section or cesarean birth, is a surgical procedure used to deliver a baby through a cut or incision made in the mother's abdomen and uterus. Healthcare providers operate for a C-section when they believe it is safer for either the mother, the baby, or both. The statistics worldwide, according to the World Health Organization or WHO, the use of cesarean section continues to rise globally, now accounting for more than 1 to 5, 21% of all childbirths. This number is projected to increase further, with nearly a third or 29% of all births likely to take place in C-section by 2030. Worldwide C-section rates have risen from around 7% in 1990 to 21% today. And in the Philippines, the rate of cesarean section or C-section stands at approximately 32.8%. Next is acute gastritis. The stomach lining becomes suddenly inflamed or swollen when someone has acute gastritis. It may hurt a lot and bother you. Nevertheless, the discomfort is temporary and often only lasts for short amounts of time. Acute gastritis is characterized by an abrupt onset and can be brought on by trauma such as injury, infection or also known as H. pylori, viruses, stress, or consumption of irritants like alcohol, NSAIDs, steroids, or spicy food. It frequently lasts just briefly. White blood cells are drawn to the site of injury in acute gastritis due to an inflammatory immune response triggered by the disturbance in the stomach mucosa. Acute gastritis can develop into erosive gastritis, which is characterized by painful ulcerations or sores, small regions of bleeding within the mucosa, and shallow lesions of the stomach lining, also known as gastric erosions. If the mucosal damage is sufficiently severe, while indigestion or upset stomach are occasionally synonymous with gastritis, the term most precisely describes the presence of inflammatory cells in a stomach biopsy, which is typically taken during an upper endoscopy. An endoscopy is a minimal invasive treatment that allows a patient to see inside the bodily part by using a flexible tube and a tiny camera. Similar to the gastrointestinal system, the word gastropathy may be used in place of inflammation if the gastric biopsy shows no sign of inflammation. Symptoms may include abdominal pain, which acute gastritis can cause nagging pain although it's usually temporary. Also, nausea and vomiting. Some individuals experience these symptoms. Temporary nature, unlike chronic gastritis, which persists longer, acute gastritis comes on suddenly and resolves relatively quickly. The statistics worldwide, approximately 50.8% of the population in developing countries suffer from gastritis. Developed countries, 34.7% of the population experiences health problems related to gastritis. In the Philippines, a study conducted in the Philippines found that the overall prevalence of gastritis in the study area was 78.8%. Specifically, 48.9% of the cases were classified as acute gastritis, while 29.9% were categorized as chronic gastritis. And on Caraga, statistics related to acute gastritis in Caraga region, the prevalence of gastritis in the study area was 78.8%. Specifically, 49% had acute gastritis, while 29% had chronic gastritis.
Nursing Health History. Level 2 student nurses of Padre Saturnino Torrijos University were assigned to the delivery room at Agusan del Norte Provincial Hospital, dated from February 19, 20, 21, 26, 27, and 28 of 2024. The student nurses made sure to obtain substantial information on the chosen case with analytic and systematic through assessment. Patient demographic profile. Patient F is a 38-year-old female of Filipino descent. She was born on September 23, 1985 in Leyte and resides in Purok 1, Buay San Magallanes, Agusan del Norte, Caraga. Patient F is of Roman Catholic faith. For the family history, Patient F's family history includes instances of ulcer conditions among various family members. For patient's past health history, Patient F has a history of significant health events. Patient F was exposed to stressful workloads due to her lifestyle. The onset of illness on February 18, 2024, Patient F was admitted to Agusan del Norte Provincial Hospital with a chief complaint of loose bowel movement with vomiting and severe dehydration, with monitoring results of blood pressure 100/80 and fetal heartbeat of 152 beats per minute. The patient was advised to deliver via cesarean section due to chorioamnionitis. Gordon's functional theory. Gordon's functional health patterns enables and guides student nurses in creating a comprehensive assessment to gather patient data and information that will help in formulating nursing care plans. Health perception and health management. Patient F stated that she has a past history of appendectomy. She verbalized that she promoted her healthy lifestyle during and after her pregnancy. Patient F does not smoke or drink alcohol. Patient preserves her health as a crucial part of taking part of her family in the future. Nutritional and metabolic pattern. Patient F weighs 68 kg with a height of 160 cm and her BMI is 26.5, which indicates that she is overweight. Patient F verbalizes that she often eats meat during her pregnancy and usually drinks 3 to 5 glasses of water. Now that patient F is hospitalized, she is in a soft diet. Elimination pattern. According to patient F, sa duha ka semana, ikaduha ra ko makalibang. Unya sige ko pangihi kada adlaw, city ko mangihi kada adlaw. As patient verbalizes. This may be due to patient's problem. For the sleep and rest pattern, prior to hospital admission, patient F describes her sleeping pattern as normal as she usually falls asleep at 8 p.m. In the evening. However, during pregnancy, patient F complains of insomnia, making her sleeping pattern alters. Health perception and self-concept pattern. Patient F stated that she does not have any feeling of insecurity about herself. Wala jud ko yung mga insecurities kay kita tanan na unique na pagkatao as verbalized by the patient. She described herself as a pleasant person who gives joy to everybody around her. For activity and exercise pattern, according to patient F, her usual exercise pattern most depends on her chores like pagpanilig, hugas plato, lakaw ug sayo ug lakaw-lakaw, which translate to sweeping, washing utensils, and early walks and walking. For the role and relationship pattern, according to patient F, she has a good relationship with her family and is close bond with them, especially with her children. Her relationship with her family is healthy. Okay man mi sa among pamilya, open man mi sa among mga problema as patient verbalized. Cognitive perceptual pattern. Patient F was conscious at the time we were conducting an interview. The patient was lying down and able to participate during the history taking. Upon assessment, there were no signs of his sensory deficits observed. She responds to verbal stimulation, coherent, and speaks articulately. Coping stress pattern. When patient F is feeling stressed, her usual response for relaxation is to pray, walk, and sell goods in her mini store. By this, patient F relieves her condition of being stressed and avoids factors that would complicate her pregnancy. In addition, patient F verbalizes her concerns and feelings around people around her, letting them know whenever she is stressed out. For the sexually and reproductive pattern, patient F is a 38-year-old female living with her live-in partner and her children. Patient F is satisfied with her reproductive life of having 6 children. She reported that her sexual activity is active. She has no history of contracting any sexual transmitted diseases or any diseases affecting her genitals. Now for the value and belief pattern. Patient F is a devoted Roman Catholic and has a strong connection with God. According to patient F, whenever she is feeling depressed or stressed, her coping mechanism is by praying.
Name patient F, age 38, date February 20, 2024, time 10 a.m. The legend, black normal, red abnormal. The instrument used are tape measure, pen light, thermometer, pulse oximeter, wristwatch, stethoscope, blood pressure apparatus, and physical assessment tool guide. For the general survey, the patient stands 160 centimeters and weighs 68 kilograms with a BMI of 26.5, which is interpreted to be overweight. The patient received on bed in semi-fowler position, awake, responsive, and coherent, with ongoing IV fluid of 30 cc B5LR, 1 liter infusion well at right metacarpal, with basal and vital signs of temperature 37.4 degrees Celsius, pulse rate of 80 beats per minute, respiratory rate of 20 cpm, blood pressure of 120/80, and O2 oxygen saturation of 96%. Patient F complains of pain on the surgical site with a pain scale of 7 out of 10. She can sit and get up in bed. The student nurse observed that she likely to stay in bed to ease the pain. Despite her situation, she is cooperative, responsive to the student nurse questions. Patient F statistics. The head circumference is 53 centimeters, chest circumference is 91 centimeters, abdominal circumference is 96 centimeters, mid-arm left 12 centimeters, right is 12 centimeters, calf 15 centimeters, right left is 15 centimeters. For the general survey, the body build, proportionate or endomorph, posture, relax, hygiene and grooming, clean and neat, attitude, cooperative, quality and quantitative speech, understandable, relevance of thoughts, logical. So we have here the physical examination, which is the IPPA, or the inspection, palpation, percussion, and auscultation. So some parts here are a normal condition, and I will only state the abnormal one, which is the skin. The skin is When palpated, the skin is warm to touch. The nails when inspection, it has a dirty fingernails upon the inspection. The abdominal contour is bloated with 6.7-inch abdominal wound incision below the umbilicus. And her neurologic assessment, her behavior, her behavior is cooperative but irritable and has a guarding behavior. Her motor functioning, she is unable to stand, slow, and limited movements.
Okay, so next is the anatomy and physiology. Acute gastritis is inflammation of the stomach lining that develops suddenly and can cause symptoms such as abdominal pain, nausea, vomiting, and loss of appetite. The appendix, on the other hand, is a small pouch located near the junction of a small large intestine, primarily known for its associations with appendicitis. When it becomes inflamed or infected, while acute gastritis and appendicitis are both conditions related to the gastrointestinal tract, they typically involve different areas of the digestive system. Acute gastritis affects the stomach lining, often due to factors like excessive alcohol consumption, certain medications, bacterial infection, such as H. pylori, or autoimmune diseases. On the other hand, appendicitis involves inflammation of the appendix, usually due to obstruction of the appendix lumen leading to bacterial overgrowth and infection. Organs affected by gastritis. First is the stomach. Gastritis is inflammation of the stomach lining, which is composed of mucous membrane tissue. The stomach lining contains glands that produce stomach acid, an enzyme important for digestion. In gastritis, these glands may become inflamed, leading to various symptoms such as abdominal pain, nausea, vomiting, bloating, and indigestion. And the second is the esophagus. While gastritis primarily affects the stomach, severe cases or certain types of gastritis, such as reflux gastritis, can lead to inflammation of the lower esophagus. This condition is often associated with gastroesophageal reflux disease or the GERD, where stomach acid backs up into the esophagus, irritation, and inflammation. Then next is the duodenum. The duodenum is the first part of the small intestine, located just below the stomach. In some cases, gastritis can lead to inflammation of the duodenum, a condition known as duodenitis. Duodenitis can cause symptoms similar to gastritis, such as abdominal pain, bloating, and discomfort. Next is the premature rupture of membrane or PROM. It refers to the rupture of the amniotic sac membranes before the onset of labor and before the term of pregnancy. Normally, the amniotic sac ruptures during labor, leading to the release of amniotic fluid, commonly known as the water breaking. However, in cases of PROM, the membranes rupture prematurely, often resulting in the leakage of amniotic fluid. PROM can occur at any gestational age but is most commonly associated with pregnancies nearing or at term after 37 weeks. The exact cause of PROM is often unknown but can be attributed to a variety of factors, including infection, trauma, cervical incompetence, multiple pregnancies, or previous PROM. And the organs affected by PROM, first is the amniotic sac. Amniotic sac membranes. PROM involves the premature rupture of the amniotic sac, which typically surrounds and protects the developing fetus during pregnancy. The rupture of the membranes leads to the leakage of amniotic fluid, which serves as a protective cushion for the fetus and helps maintain a stable intrauterine environment. The next is the uterus. It is the organ where the fetus develops During pregnancy, when PROM occurs, the rupture of the amniotic sac can lead to a decrease in the volume of amniotic fluid within the uterus, potentially impacting fetal well-being and increasing the risk of complications, such as cord compression. The next is fetus. From PROM can have direct implications for the fetus, particularly if it occurs before the fetus has reached full term. Decreased levels of amniotic fluid resulting from PROM may increase the risk of fetal compression, umbilical cord compression, and subsequent fetal distress. The next is the placenta. The placenta is the organ that provides oxygen, nutrients, and waste elimination. For the developing fetus, although PROM itself does not directly affect the placenta, complications associated with PROM, such as preterm labor or delivery, can impact placental function, fetal well-being. Then, the reproductive organs. PROM can have implications for the mother's reproductive organ, including the cervix and vagina. The rupture of the amniotic sac can lead to increased vaginal discharge or leakage of amniotic fluid, which may require assessment and management to prevent complications, such as infection. In conclusion, gastritis in a baby born to a pregnant woman with gastritis is not a direct consequence of the mother's gastritis during pregnancy. Gastritis typically does not pass directly from the mother to the baby in utero. However, some certain conditions and factors can predispose infants to gastritis. The first example is the H. pylori infection. Helicobacter pylori infection is a common cause of gastritis in both children. If the mother is infected with H. pylori, there is a small chance that the bacterium could be transmitted to the infant during or after birth, leading to gastritis in the baby. And genetic predisposition. Some infants may have a genetic predisposition to gastritis or other gastrointestinal conditions. If there is a family history of gastritis or related disorders, the baby may be at high risk of developing gastritis. Environmental factors also has affect the exposure to certain toxins, medications, or pathogens after birth can contribute to the development of gastritis in infants. For example, ingestion of contaminated food or water can introduce pathogens that irritate stomach lining and lead to gastritis. Immune system development. The immune systems of newborn babies is still developing and may not be fully equipped to handle infections or inflammatory responses. These can make infants more susceptible to infections like H. pylori and other pathogens that can cause gastritis. Then lastly is the dietary factors. The introduction of solid foods or formula feeding may also play a role in the development of gastritis in infants. Certain foods or ingredients may irritate the baby's stomach and lining and contribute to inflammation. The pathophysiology of gastritis in infants is similar to, to adults, involving inflammation of the stomach lining. However, in infants, the presentation may be different and symptoms such as irritability, poor feeding, vomiting, and failure to thrive may be observed. Diagnosis typically involves clinical evaluation, possibly along with imaging studies or endoscopy with biopsy. Treatment for gastritis in infants may include medication to reduce stomach acid, antibiotics if there is evidence of bacterial infection such as H. pylori, and dietary modifications. Management also focuses on addressing any underlying causes or contributing factors to alleviate symptoms and promote healing of the stomach lining. Parents need to seek medical attention if they suspect their infant has gastritis or any other gastrointestinal issue. In conclusion, gastritis in pregnant women can present unique challenges due to the physiological changes and considerations related to pregnancy gastritis. Gastritis inflammation of the stomach lining can occur during pregnancy due to various factors such as hormonal changes, increased stress, dietary habits, or pre-existing conditions. While gastritis itself doesn't directly affect the fetus, it can indirectly impact maternal health and potentially influence pregnancy outcomes. Pregnant women with gastritis may experience exacerbated symptoms such as nausea, vomiting, abdominal pain, and discomfort, which can contribute to maternal stress and affect overall well being. Moreover, severe gastritis may lead to nutritional deficiencies, dehydration, or complications like gastrointestinal bleeding, which can pose risks to both maternal and fetal health.
Next is I'm going to discuss the laboratory result of the patient. First, we have the hematology. A drop in hemoglobin levels from 135 on February 18 to 121 on February 21 is noted, especially considering the reference range of 110 to 150. While both values fall within the normal range, such as decrease could indicate a trend worth monitoring. It might suggest factors such as blood loss, decreased red blood cell production, or increased red blood cell destruction. Next, we have the hematocrit. These laboratory results indicate a decrease in hematocrit levels between February 18 and February 21. On February 18, the hematocrit level was 0.410, which was within the reference range of 0.370. Next, we have the red blood cell count. Result on February 18, 2024 is 4.35, and on result on February 21, 2024 is 3.93 with a reference range of 3.50 to 5.00. The remarks is decrease, so this could be indicative of various conditions such as anemia, bleeding, or certain types of infections or disease affecting the bone marrow or IBC production. Next is the MCV or the mean corpuscular volume. It measures the average size of the red blood cells. In this case, the MCV count was 94.2 on February 18 and increased slightly to 95.0 on February 21. Both values fall within the reference range of 80.0 to 100.0, indicating that the size of the red blood cells is normal. Next is the MCH or the mean corpuscular hemoglobin, measures the average amount of hemoglobin in the red blood cells. Looking at the results provided, on February 18, the MCH level was 31.0, and on February 21, the MCH level was 30.8. Both results fall within the reference range of 27.0 to 34.0, indicating that the MCH levels are normal. The slight decrease from 31.0 to 30.8 between the two dates is likely not clinically significant as it falls well within this normal range. And next is the MCHC or the mean corpuscular hemoglobin concentration. It's a measurement of the concentration of hemoglobin in each volume of packed red blood cells. A normal range for MCHC is typically between 320 and 360 grams per liter. In the case of the patient, the MCHC results on February 18 was 330 grams per liter, which falls within the normal range. However, the results on February 21 decreased to 324 grams per liter, is still within the normal range but slightly lower than the previous measurement. This slight decrease on MCHC could be indicative of various factors such as changes in hydration status, nutritional deficiencies, or underlying health condition. Next is the white blood cells. This laboratory result shows an increase in white blood cells count between February 18 and February 21. On February 18, the WBC count was 7.53, which is within the normal reference range of 4.00 to 10.00. However, on February 21, the white blood cell count significantly increased to 13.11, which is above the normal range. An elevated WBC count can indicate various conditions such as infection, inflammation, or a response to stress or injury. And next is the neutrophils. These laboratory results indicate an increase in the neutrophil count between February 18 and February 21. Neutrophils are a type of white blood cells that plays a key role in the body's immune response to infection. An elevated neutrophil count, known as neutrophilia, can occur in response to infection, inflammation, stress, or other medical condition. In this case, the reference range provided for neutrophils is 50.0 to 70.0. On February 18, the result of 72.7 was slightly above the upper limit of the reference range and suggesting a mild elevation. By February 21, the count had increased further to 82.8, which is significantly above the upper limit of the reference range. And this increased neutrophil count may indicate a more significant immune response, possibly in a response to an infection or inflammation. Next is the lymphocyte. A decrease in lymphocytes count from 19.2 on February 18 to 11.7 on February 21 is noted, especially considering that both values fall below the reference range of 20.0 to 40.0. Lymphocytes are type of white blood cells that plays a crucial role in the body's immune response. A low lymphocyte unit or count, known as lymphocytopenia, may indicate a weakened immune system, possibly due to factors such as infection, autoimmune disorders, medication side effects, or certain medical treatment like chemotherapy. Next is the monocyte. These laboratory results indicate the levels of monocytes in the blood over a period of a few days. The result on February 18 shows monocyte count of 7.7, which is within the normal reference range of 3.0 to 12.0. However, the result on February 21 shows a decrease in the monocyte count to 4.9, which is still within the normal range but lower than the previous result. This fluctuation could be due to various factors such as changes in the body's immune response, infection, inflammation, or other physiological process. Next is the eosinophil. This laboratory result indicate a slight increase in eosinophil levels from 0.2 on February 18 to 0.5 on February 21. Eosinophils are type of white blood cells that is often associated with allergic reaction and parasitic infections. However, the values provided are below the lower limit of the reference range of 0.5 to 5.0. It's suggesting that the levels are still within the normal range, and it's essential to consider other factors and symptoms when interrupting this result is isolated changes in eosinophils levels may not always indicative of health issue. Next is the basophil. This laboratory result indicates the level of basophils in the blood. Basophils are type of white blood cell involved in the body's immune response. In this case, the results show that on February 18, the basophil count was 0.2 and on February 21, it increased slightly to 0.3. Both values fall within the reference range of 0.0 to 1.0, indicating that the levels of basophils are normal and there are no cause for concern regarding any potential abnormalities in the immune system.
Next is the platelet count. The result on February 18, 2024 is 538 and on February 21, 2024 is 430 within the reference range of 150 to 450. The remarks is within the normal range. While both values are within the normal reference range, the decrease from 538 to 430 within a few days may indicate a transient fluctuation in platelet levels.
Next is the blood chemistry. First, we have the sodium. The laboratory results indicate the concentration of sodium in the blood measured in millimoles per liter. On February 4, the sodium level was 132.2 millimoles per liter, and on February 18, it increased slightly to 132.5 millimoles per liter. Both values fall within the normal range of 125.0 to 148.0 millimoles per liter, indicating that the sodium levels are within the expected range and there is no cause for concern in regarding abnormalities in fluid balance or nerve function. Next is the potassium. The laboratory result indicate the concentration of potassium in the blood measured in millimoles per liter. Potassium is an essential electrolyte involved in various physiological processes and including muscle function and nerve transmission. On February 4, the potassium level was 3.96 millimoles per liter within the normal range of 3.50 to 5.30 millimoles per liter. However, on February 18, the potassium level increased to 4.38 millimoles per liter, still within the normal range but slightly higher. While both values are within the normal range, the increase from 3.96 to 4.38 millimoles per liter within a few days may indicate a slight elevation in potassium levels. Next is the chloride. These laboratory results indicate the level of chloride in the blood measured in millimoles per liter. On February 4, the chloride level was 107.2 millimoles per liter, which was slightly above the upper limit of the normal range, 98.0 to 107.0 millimoles per liter. However, on February 18, the chloride level decreased to 103.1 millimoles per liter. Falling within the normal range, the decrease in chloride levels from 102.2 the decrease in chloride levels from 107.2 millimoles per liter to 103.1 millimoles per liter suggests a potential normalization of the electrolyte balance. Next is the creatinine. The laboratory result indicates the level of creatinine in the blood measured in micromoles per liter. Creatinine is a waste product produced by muscles metabolism and is filtered out of the blood by the kidneys. In this case, the creatinine level is 79.86 micromoles per liter, which falls within the normal range of 53.00 to 97.00 micromoles per liter. This suggests that the kidney function, which plays significant role in cleaning creatinine from the bloodstream, is within the expected range. Overall, the results indicate that there are no abnormalities detected in the kidney functions based on the creatinine level. Next is the urinalysis. First, we have appearance of the urine. The remarked urine appearance is slightly hazy, indicates that there is a slight cloudiness or turbidity in the urine sample. A slightly hazy urine appearance may be normal and can result from various factors such as the presence of crystals, mucus, or cellular debris in the urine. And it could also indicate the presence of bacteria, protein, or other substances in the urine which may be associated with urinary tract infection or kidney dysfunction. Next is the chemical examination for specific gravity. Specific gravity of a substance is a measure of its density compared to the density of water. In the context of urine analysis, specific gravity indicates the concentration of solutes in the urine, reflecting the kidney's ability to concentrate or dilute urine. A specific gravity results 1.020 indicates that the urine is moderately concentrated. In other words, there is a moderate number of solutes present in the urine compared to pure water. This value falls within the typical range for urine's specific gravity, which is generally between 1.005 and 1.030. A specific gravity of 1.020 suggests that the kidneys are functioning within normal parameters as they are able to concentrate the urine appropriately. Next is the pH measurement. pH measurement of 6.0 indicates that the substance are being examined is slightly acidic. pH is a measure of the acidity or alkalinity of a solution. With values below 7 indicating acidity, 7 being neutral and values above 7 indicating alkalinity. In this case, a pH of 6.0 suggests that the substance may have some acidic properties. It's important to consider the context of the examination and substance being tested to understand the significance of the pH result. Next is the glucose. A negative result in glucose examination is generally considered a positive outcome indicating normal metabolic function. Next is the protein. During pregnancy, protein. Cut. Next is the protein. So we have here the result of a trace and it is normal. Because during pregnancy, it is a common for a small amount of protein to be present in the urine. This is typically considered normal and is often attributed to the increased filtration of the kidneys during pregnancy. The kidneys work harder to eliminate waste product from the mother's body as well as those produced by the growing fetus.
Next, we have here the bacteria. There are few bacteria found in the urine and it is abnormal. A urine sample has been tested and found to contain a small number of bacteria. Bacteria in the urine can sometimes be a sign of urinary tract infection, UTI, or contamination during the collection process.
Next is we have the WBC. So we have the result that there are 23 to 30% of WBC in the urine and it is abnormal. A microscopic examination of urine showing 23 to 30 white blood cells per high power field suggests that the presence of inflammation or infection in the urinary tract. Next is the epithelial cells. So the result is increased epithelial cells are present in the urine sample. Epithelial cells are cells that line the surface of organs and cavities in the body, including the urinary tract. Next, we have crystals, urates. Finding a few urate crystals in the urine may be normal and does not necessarily indicate any underlying health issues. However, in some cases, an increased presence of urate crystals could be associated with conditions such as gout or kidney stones. Next, we have the serology. So we have the type of examination for hepatitis B surface antigen. So the specimen is the plasma and the method is ICT. And for the result, the HEPA is non-reactive and it is normal. It indicates that there is no evidence of active hepatitis B infection at the time of testing. And lastly, we have the whole abdominal ultrasound report. The liver appears enlarged with mild diffuse increase in parenchymal echogenicity. Contour is smooth, no focal mass is seen, and there is normal branching of the hepatic vessels. The intra and extrahepatic ducts are not dilated, and the common ducts measure 3.9 millimeters. The gallbladder is physiologically distended with non-thickened walls, and it measures 7.5 times 2.8 centimeters. Low-level internal echoes are noted. The visualized pancreas is normal in size, contour, and echo pattern. It measures 1.2 times 0.7 times 1.2 centimeters. No discrete nodule seen. Pancreatic duct is not dilated. Spleen is unmarkable and measures 9.1 times 4.9 centimeters. Right kidney measures 11.7 times 3.9 times 3.9 centimeters. Cortical thickness is 1.1 centimeters. And the left kidney measures 11.1 times 5.4 times 5.0 centimeters, and cortical thickness is 1.0 centimeters. The kidneys are normal in size and echogenicity with good corticomedullary differentiation. Both central echo complexes are intact. A few scattered small dense echoes are present in both upper collecting system with sizes ranging from 0.22 centimeters to 0.28 centimeters. A well-defined thin-walled cystic structure with thin internal septation is seen in the right superior pole measuring 1.4 times 1.1 times 1.1 centimeters. No demonstrable hydropherosis appreciated bilaterally. Ureters are not visualized. Urinary bladder is adequately distended with non-thickened walls. No abnormal intraluminal echo seen. No ascites detected and note of dilated bowel loops. Within the gravid uterus is a single live fetus presently in cephalic presentation with the following biometric parameters. Biparietal diameter measures 7.5 30.77 millimeters, 30 weeks, 2 days. Head circumference measured 278.22 millimeters, 30 weeks and 3 days. Abdominal circumference measured 260.54 millimeter, 30 weeks and 1 day. Femoral length is measured 57.75 millimeters, 30 weeks, 1 day. Estimated fetal weight is 1,537 grams or 3 pounds 6 oz, and the expected date due is April 28, 2024. Fetal heartbeat is regular with a rate of 145 beats per minute, and there is a good cardiac activity. Placenta is implanted anteroventrally and laterally to the left with a grade 2 maturity. There is no encroachment into the internal OS nor show any abnormality. Amniotic fluid is below normal 7.3 CFL. Visualized endocervix appears closed.